And as Sujina said, I'm going to be talking about, I'm going to be speed talking about implementation and maintenance. And so I will pause as we go along, and please feel free to jump in with questions that you have along the way. My understanding is that you're at different phases of implementation. So I want to make sure that we're talking about what really feels most relevant for you. And I'll have some slides that I'm just going to touch on very briefly, and you'll have those for later. And they may have quite a bit of detail in them, but I just sort of want to get them out on the table. And certainly if you had questions about them, we could pause and dig into it a little bit more. So I'm going to be talking primarily from the perspective of the work that I led at UW Health when I was there, and we did implement the collaborative care model. I'm a psychologist, by the way, and I was saying, oh, I'm semi-retired because I never seem to really retire all the way. So I'm no longer at UW Health, but I'm going to talk about that perspective. And I did have a prior opportunity to work in more in the primary care behavioral health model of integration. So collaborative care was newer for me when I first went to UW Health. So with no further ado, I think I'll just jump right in and we'll get rolling. That's okay. So in terms of key learning objectives, I think if you leave this discussion with one, true appreciation, or having really deepened your appreciation of one thing, it will be the importance of perseverance. So when I was in the consulting world, one of the things that we did was a lot of change management. And at the time, we had a very simple model, a seemingly simple, right, model, which was head, heart, hands. And so I think that intellectually, we all get that things aren't going to go smoothly. They're not going to go sort of in a linear fashion. But I don't think that we always really appreciate that, from a sort of lived sense perspective. And it can be easy to get discouraged, or I think often organizations might throw their hands up and say, that's it, it's not working. And so I think it's really important to think about, okay, how do I stay resilient through all of this if you're leading the project or if you're working, in the implementation, because it's not always pleasant and it's not always easy when things seem to be going off the rails. And I think one of the ways, at least for me, that I can maintain my resilience is keeping my sense of humor. So, I think just I'll leave it there, but I think sticking with it is one of the key things in terms of both successful implementation and then being able to maintain the work. So I do think context is everything. So just say a little bit about what our context was for our implementation. A large academic medical system. We had over 20 primary care clinics at the time, and the directive or the goal was to implement in all of those clinics. And so that was sort of what it looked like. And we had, I think we committed to a 2-year timeline to do that full implementation. At the time, the organization as a whole was really going through this shift in terms of, instead of thinking about pilots, really thinking about test of change. So I think language does matter because pilots are like, it's not a TV show, right? Where it's like, oh, people didn't like it, so we're going to cancel the show. But that's, I think, what happens sometimes when you think about things as pilots. And as a matter of fact, I'll give you a couple of examples that were good learnings for us. And my hope would be that they might be helpful for you to hear. And thinking about it rather as a test of change. We realize that something doesn't come out of the box and magically work right off the bat. There's the need to test things, there's a need to tweak, and we are going to continue down this road, but be ready for the ongoing sort of testing, and it's not care as usual. So I think it takes time to get to that final product. We had a stalled implementation. I came into the project at the end of the design phase when it was just getting launched in 2 clinics. And at the time, that early on, they still were talking about it as pilot. So and I'll talk a little bit more about, I think, what got in the way or what caused that stall. And it might be, again, helpful for you to think about. The other thing about the environment is, very strong sort of collaborative environment and decision making. So, always tons of people on every email, a lot of entities, different departments, the medical school and population health and behavioral health, and everybody and his brother, has to be involved in making decisions. And that's just a reality. It might not be the most efficient way to work, but I'll tell you, if you ignore that, and I don't know what it's like in your organizations, but if you ignore that, you can get off track. We didn't predict a pandemic in the middle of implementation. That threw a little monkey wrench into the work. And I'm sure today you were all still sort of dealing with a different phase of that, and I'd be curious to see how that's playing out. Very strong population health focus. As a matter of fact, really collaborative care was seen as a population health priority and initiative, and behavioral health was really in charge of a successful implementation. And then obviously primary care sort of held a large part of the execution. So lots of different pieces there. About probably a year and a half before I left, we also became involved with an NIH grant, which was looking at the efficacy of screening for opiate use disorder in primary care. And it meant we integrated that population into our collaborative care model. And then finally, something that I assume everybody's still seeing today is the extreme shortage of behavioral health providers. So if I thought, if anything was going to sort of get in the way of us meeting our timeline, it would be the fact that we might not be able to find providers. And I don't know, did Dr. Shanda Wells, has she done a session for you already, Sujina?
Yes, she has.
Yeah. So some of you were able to meet her. She managed to hire all of the providers in that 2-year time frame, even though there is a real shortage. I'm going to pause there just for a second. Any questions so far? That was sort of our world in which we launched. Okay. So our primary objective for implementing collaborative care was it was part of a larger behavioral health integration strategy. And I was really brought into the organization to integrate the providers that were there already, they were pretty disconnected across the system, and create an infrastructure for behavioral health. And really it was with the single most important goal was to improve access for patients to behavioral health care. Also, I've mentioned the population health approach, and then to improve a patient-centered approach to care. So I think it's really helpful to keep that at front and center for people, because I think most of your stakeholders see that as value add, certainly, to bring care to the patients where they are. These are a couple of slides I'm going to just go through quickly for what it's worth. I think that sometimes systems are challenged in doing implementations because there's sort of not enough structure or methodology in place to guide your work and sort of keep you on track. And like, I'm a big model person, so I find it very helpful to have something to sort of refer back to, like, how are we doing with this, and are we going where we need to go? And at the Fogarty Center at NIH, they define implementations science simply as methods to promote the integration of research into the real world, right, into your practice. So collaborative care is an evidence-based model. It's pretty regimented in a lot of ways, but we live in the real world. We're not implementing things in a lab. So you have to be mindful of that. And I'm just sharing the RE-AIM framework as one such model that is used. You might be using something different. There's not a right or wrong, but it gives you a sense of sort of how, having a model keeps you cognizant of all the different parts you have to pay attention to at once. So with the idea that the impact your program will have really is made up of reach times efficacy. So are you understanding the environments and the characteristics of patients and providers and the clinics that you're implementing in and who's affected? And are you doing what you thought you would do with the, going into it? Is it having the effect you want? So I'm not going to say more about this. There's a lot there, but there's a lot of material available. If I don't know if you have a QI department, you might have a model that they like to use. In any case, just want to land that principle. And if we look at strategies to boost sustainment, so that would be really in the adoption phase of the RE-AIM framework. There really are a number of things that I think end up being important. So again, I had referenced using the evidence, like you want high fidelity to your model. And that was something that we remeasured, as time went on, and it helped us understand as a whole how we were doing, and also sort of clinic differences. Like you may end up having clinics that have very high fidelity, and then others maybe not so much, and it helps you to identify, well, maybe that's something we need to dig into and understand. But you live in the real world, right? So we're not, again, going to be able to control everything at the outset. Put the right role in the driver's seat. So it's not always going to be your normal hierarchy, like your operational leader who's going to come in and lead something. So, think about the phase of project that you're in. And I think, frankly, that was one of the things that really helped us get some traction. And I don't think it was due to me specifically, but I think it was the ability to have somebody in the role who had implemented before and sort of had a sense of, what that would look like over the next couple of years, and was realistic about, again, being in the real world. You absolutely have to collaborate, I think, on most implementations, but it's very important with this model, given the degree to which, I'm behavioral health, and we're playing in the primary care arena. We don't control everything, and nor should we. You absolutely have to collaborate. Have I mentioned you have to stick with it? You can't give up. Let's see, measuring and making metrics readily available is important. That's the other reason I think implementations kind of, like they just kind of fade off into the sunset. And I don't know if you've had that experience ever in your organization, but they're implemented and they just kind of stumble along and nobody's really paying attention to, what's happening. Is it working? Are patients getting better, et cetera? So we actually created 2 different dashboards, and it allowed people to go and pull whatever data they felt was relevant for them, rather than waiting to like push out a report, that they would get. And one was sort of that high level, more project-based, like outcomes. And then the second one was more really specific, clinical outcomes and process measures, so that people could see what was happening real time. And then that was in conjunction with a reporting workbench, which was drawn from the disease registry. So, down to the individual level of patients, you could see, oh my, we haven't consulted on this patient, in, 4 months or whatever, or look at this person isn't getting better. Have we done something different? So making that all available to people and encouraging them to use it and teaching them how to use it is really, really important. Creating an enduring structure. So in other words, not being like, okay, that's it, implementation's done, now it's business as usual, that you really need to keep some structure in place. Like your project team at that point can morph into a different type of entity that is then paying attention to what's going on. In our organization, what that looked like was the physician champions, and were joined by the usual operational leaders from primary care. So we switched out some members, and they're really doing some deep dives, some process improvements, like choosing 2 things that, don't seem to be going well, and digging into those. And there's always more problems to be solved. I think, so evolving your structure to match the phase that you're in. You got to appeal to what matters and leverage people's self-interest. So, I think all of the players have to see it as value add in order to buy into it. And then finally, to get senior leadership on board and keep them there. There's a lot of shiny objects out there that it's hard to keep everybody's attention. But I was lucky enough, certainly, to have, I reported to the senior VP of ambulatory, and she was a real champion for the implementation, and she kept it on the CEO's radar. So that was very important. I'll just pause there. See, do people have any questions? Does that sort of intuitively make sense to you, that those things would be important? Maybe. All right. So in terms of like some of the additional suggestions or things that we learned along the way is, there's this balancing act of understanding the characteristics of your setting, and right, we don't just have one setting, and I don't know, again, what your environments might look like or what your goals are in terms of implementation, but I think no 2 clinics are alike. As much as an organization tries to create those usual practices and consistency across the system, you're going to have, like, we had a clinic in DeForest, Windsor, which was outside of Madison, that was more rural, and it had a much older population, people who had been going for care in that clinic for years. and then compare that to a clinic that's close to downtown Madison that has a much more, like a much broader range of patients. So that's real, but you have to be careful of terminal uniqueness. So I said earlier that I think one of the places where we went off track that created a stall was there was a decision to staff the behavioral health specialist position with two different skill sets. And one was RNs who didn't have behavioral health experience. And in the other clinic, it was behavioral health clinicians. And I know systems sometimes use RNs or they use clinicians, but for whatever reason, the design team thought we're going to do both, and one here and one there. And it just didn't work. And there were a number of reasons for that. Probably, it wasn't probably the only issue, but really, things were not going where they needed to go. And the clinic with the RNs, I think, really struggled to figure out like what their roles were and how collaborative care worked. And, it just, suffice it to say, it didn't work well. So we had to go back to the drawing board, and I'll talk a little bit more about, keeping that appreciation for learning and failure, and being okay with that. But and then you have to understand the population to be served, as I mentioned, thinking about the difference across clinics. So, do you have a clinic where, maybe because you have an addictionologist, you have a very high level of substance use disorder, something like that. And then finally, to design from a primary care perspective. These are workflows that happen within the primary care setting. It's very important to understand, what is the MA facing day to day? What's the workflow for getting a screening, to the provider before they see the patient, all those kinds of things. And then I'll say it again, you're going to be really sick of hearing this, but if at first you don't succeed, try again. So don't give up. I talked a little bit about our failed pilot, and then we had the pilot that never ended. So again, this was something that Shanda Wells happened to be the person in the role that before deciding on collaborative care, actually, it was decided to, do a pilot in one of the pediatric clinics and have a behavioral health provider there. And that was utilizing more the primary care behavioral health approach. But, so they placed her in the clinic, and then it was like they forgot about her, right? And so she was just there years later. And, she was doing her work, working well with the providers. The clinic was doing fine, but really there wasn't any attention to, is it accomplishing anything? Is it cost effective? Is it really helping patients? Anecdotally, I think people would say it was, but it just kind of kept, bumping along. And I think that hurts your credibility with the organization when you allow it to be sort of ill-defined, and you don't have sort of a plan for how you're going to look at it and whether it's working and what you're going to do next and when you're going to do the next thing, that kind of thing. I would say here, question your most dearly held beliefs. So we had a really wonderful primary care physician champion as part of our team. And Elizabeth felt very, very strongly that the warm handoff was absolutely essential to the success of the model. And so she spent, I think, a lot of time digging into, when that didn't happen and trying to get people to do it, et cetera. And then the pandemic happened, and we went to remote care, practically overnight for a period of time. So then all of a sudden, the warm handoff had to look very different, or maybe it didn't happen at all in the same way. And so, that was sort of a way of forcing us to look at something we had believed to be true, and questioning it. And then finally, get perspectives of people who are maybe outside of your immediate, they might not have like a specific role within operations, but you really appreciate their perspective. So an example I would use is that I would, potentially go talk to our philanthropy person, or our who was very tuned into what patients were saying and what the community thought, or our person who was really leading all our DEI efforts, those kinds of things. Thoughts? Are these things that again you've run into, or any thoughts you want to share about that, or questions you have about what we experienced?
David, you've raised your hand. Do you want to unmute yourself? And
Oh, sorry, I didn't see that. Hi, David. Are you on mute here? I can't hear you. Let's see.
yeah, we can't hear you for some reason.
Doesn't look like you're muted.
We can't hear you still. Do you want to type in your?
You want to type into the chat? Yeah. Sorry, I had my chat box closed, so I wasn't even seeing people were responding. I apologize.
So he said earlier, you said you decided to screen for substance use. What did that look like? Why was it a special effort?
Yeah. So that's sort of a whole other can of worms, right? And so I have a slide coming up, so we'll just preview that now. But the way we implemented was to incrementally bring diagnostic presentations in, just to sort of chunk the work. So we first tackled depression. So built the disease registry for depression and saw patients who were, gave the PHQ-9 and saw patients with depression. Then we added in anxiety. And then it was with the advent of the NIH study that we brought in patients who had substance use disorder. And that, frankly, it was more, it was less like bringing anxiety in, just another diagnosis, because we had to change the team makeup a little bit in the clinic. We actually added a addiction psychiatrist as one of the consulting psychiatrists, so that specialty would be represented. There aren't necessarily good ways to screen for opiate use disorder. It gets very sticky. So that was something we spent a lot of time on. What do we use to assess that? And then, of course, you've got stigma on top of that. And I feel fairly convinced that stigma related to substance use is even, more pronounced than it is for mental health. And then, there's of course legal implications too, because sometimes people are taking drugs illegally, so they are going to be less likely to admit it. But really the purpose of the study was to look at whether screening patients in primary care for opiate use disorder yielded, whether it was helpful or not, whether it worked. And so, that was still a question on the table when I left. The study's still ongoing. And but it did add a pretty big challenge to everybody's plate, because we did have to add some workflows and make some changes. Does that get at your question, David? Okay. Important thing to try to do to improve access for that, certainly. But and I would say we were also very lucky in that we were doing that as a test of change in 2 clinics. And in both clinics, we had a PCP who was an addictionologist as well. So, really, they were clinics that already drew a fairly high percentage of, patients who had opiate use disorder, because they had the comfort level. I would say that's probably the other thing is that my experience, at least, was that the PCPs, and when I say PCP, I mean NPs and PAs too, and I never know exactly how to refer to that whole group, but that they had a higher comfort level in dealing with depression and anxiety than they did in treating substance use disorder. So there were, it was quite complex, but we did that, in conjunction with the University of Washington. And, the reason we did it at that time was because the study became available. And because we had lots of patients who were dying from overdose, right? It was extremely relevant. Okay, let's see, where are we here? This is a lot of information. So again, I'm not going to read you everything on this slide, but just something to think about. And I call this marketing, but it's really just how do you get this out in front of the organization, and sort of keep it, on people's radar. And it isn't treatment as usual, and you really want to keep that point front and center. And so I just had here were some learnings that we had was, to get invited to the right meeting. So show up. Good example of that was the primary care departments had there's a name for it, but it's sort of a town hall retreat, that they did quarterly, and brought all of the providers together. And one of the things that they would generally do is be able to visit different stations in the room to learn about things that were happening. And so this was something that, we wanted to show up and be able to share with them. It's, coming to a clinic near you soon. So we wanted them to know about it. Focus on those you want to influence or convince. So, thinking about, what different groups of people or individuals find compelling, and getting the word out to them. Tricky, but providing regular updates without inundating people. I'm sure you all have the same experience, but it's like if I get another email, I'm just my head's gonna explode. And so really it has the opposite of the desired outcome, which is people just don't pay attention because they're overwhelmed. So finding ways to do it that are a little less overwhelming. So, putting an article in your newsletter or blog, or putting it on SharePoint, or getting on the radio and doing a radio spot on it. Don't be shy about sharing success. And when you're doing that, you're focusing on outcomes, not effort. So that goes back to the importance of measuring what we do, so we know we do have outcomes. Using word of mouth. So, just, sort of getting that chain going. I'm always a big believer in share the credit and assume the responsibility. So if you're leading the project or you're one of the key players, ultimately you do have to be accountable for, where things are going and how they're succeeding. But, certainly none of us do things alone, and it's really important to highlight, the contributions that people make. And then working with other departments. So I think there's some things that some players that are really obvious, like for us, it was Pop Health, School of Medicine, the emergency department. But don't forget, like your revenue cycle folks, when you get to the point where you're going to implement your payment model, your billing and all of that, you're going to want to have had your revenue cycle folks involved earlier on. And our rev cycle people, I think they thought it was really cool, and they were really kind of excited to be involved in it and trying to like solve some of the billing problems and challenges. And then our IT department, which was invaluable. So you also want to get support from them. So I wanted screening measures to be built into the EHR, so it was sort of seamless. But that's a lot of work for them, and they've got a lot of priorities. So by engaging them earlier on and sort of making them a key part of the project, they were really invested in helping to facilitate that. So I think I've already talked about matching your structure to support your project phases. So again, thinking about your design, makeup of your design team might be different than, your implementation team, and then moving into operations where you want to keep tweaking things. So just being cognizant of that, so you don't sort of stay stuck in one speed. Your design team, I think, think broadly about who the stakeholders could be, and get your good thinkers there. Sometimes it's not people, again, who would be intimately involved in the day-to-day, but, they're always a good creative thinker. They always ask good critical questions, whatever. Make sure you're sort of balancing clinical and business aspects, involving key decision makers, so that you've got some clout. Identify potential naysayers at that point. It was interesting that, and this is secondhand, that I heard during the design phase. Well, I heard it from him after the design phase, but the vice chair of psychiatry, who I had to partner with closely, obviously, on things, didn't really think collaborative care was the right way to go. And so he was a potential naysayer, right? And so he supported it, once it was decided. But I think it would be important to understand how somebody so key in operations might have questions about, is this the most cost effective? Are we going to reach the most number of people by using this model? Thinking about your objectives going in. So I think I already mentioned it was a population health initiative owned by primary care and led by behavioral health. So if that's not complicated enough. Already mentioned some of these other things. Don't skimp on good progress. We were very, very lucky to have amazing project managers. And, that was just so essential for us to be able to keep our momentum going. I think that's another reason that implementations can stall, is that we all have way too much work to do and too many priorities. And it's really easy, to have trouble keeping the full court press going, right? To make sure we keep moving things ahead. We instituted a weekly call with our HR recruitment person, and talked about what are creative ways we can find some talent, to be able to staff this. So, don't skimp on those processes, even though they take time and commitment, and you got to find the brain space for them. It's, you gotta sort of keep that momentum. Your implementation team, any thoughts or questions, or those things that you guys have done yet, or you're thinking about doing, or been challenged with? I'm curious to know if anybody has been in the hiring process trying to recruit, behavioral health specialists for your roles, or maybe you're not at that point.
We're not at that point yet.
Not at that point yet. Yeah. I think, I just think it's a huge challenge. And I was really, and at the same time, I was really amazed at how we were able to, attract people. And I think some of it is you're going to have clinicians who, if they don't have the experience already, I should say this, I think, having experience in an integrated model is probably less important as a characteristic than personality characteristics. And so, and that's true for your consulting psychiatrist as well, right? You're not doing care as usual. So does your behavioral health specialist, like you've got a psychologist who hasn't really worked in that model, but are they very highly collaborative? Are they comfortable with doing a brief, relatively brief treatment, working at a fast pace? That was one of the things, hiring wise, I think that stalled our project the first go round. One was having the nurses who couldn't quite figure out, like, what am I supposed to be doing here? And the other was hiring clinicians who probably, like, they had come from a much more long-term model, do therapy once a week for 50 minutes, and which is fine, but you have to think about people having sort of the right characteristics that they can adapt the way that they work to this new environment, because that's key, right? If the goal isn't to be co-located, right, and do therapy in the clinic the way you're doing it in specialty care. You'll be jammed up, and you're not going to get the kind of outcomes necessarily that you're trying to measure. Same is true for the consulting psychiatrist, right? That's a very different way of working, right? All of a sudden, I'm not seeing the patients. I'm consulting on a regular basis about patients and making recommendations, and we actually had really pretty good luck with that. And I would say that we ended up with 2 or 3 people in that role, because they none of them did it full time. And I think they probably, between them, may have seen a patient in person maybe 3 times over the course of a year, which is really very good. So there will be times that potentially the psychiatrist wants to meet with somebody, for a one-time in person, and that's perfectly okay too. So so those things are, are super important, I think. Any other thoughts about that as you kind of ramp up? Oh, go to the collaborative, what is it called? It's the Collaborative Health Family Conference. Oh, sorry. Somebody,
CFHA.
yes, CFHA. Yeah.
Collaborative Family Healthcare Association.
Yes, that conference is like worth its weight in gold. Yeah. Great way to recruit. And also a lot of fun, great group of people. It's really a good conference. So I mentioned here in terms of, some of your ongoing makeup. I think I've mentioned a lot of this. Oh, educate is needed. So this is something this was a learning for me that's worth mentioning. So we had physician champions on our actually every phase of the project. And we had a champion from primary care and one from psychiatry. And they were probably the least familiar sort of with organizational structures and just because of their roles, right? And so when we were really coming to the end of the implementation phase and ready to move into more of a maintenance or operational phase, there was sort of a lot of churn. Like people were feeling really like we were trying to push them out of this super important work that they'd been dedicated to at that point for, more than 2 years. And they had a lot of skin in the game. They were very, very dedicated to the work. And it finally occurred to me that they didn't even really, like, I think maybe our psychiatrist said it. She said, like, what's operations? Like, and of course it had never occurred to me like that people wouldn't necessarily know the difference or that there are phases of work. And so we did some work on just understanding how, a project gets handed off to your operational structure, because you can't maintain some sort of project team and structure forever. That's not going to work any better than not having a strong project structure. And so the idea really is to fold as much into normal operations as possible, so it becomes routinized, so it becomes, this is just the way we do the work. And so we kind of took a giant step back, did that education, so everybody on the team was sort of a level playing field. So both our clinical people and our administrative people all had sort of a similar understanding of what we were trying to do. Let's see, other things here I'd call out. I think we've mentioned a number of these. Let's take a quick look at chat. Oh, another shout out for CFHA. Okay. There we go. Time to transition. So you remember I mentioned the head, heart, hands model. So head is sort of the intellectual understanding of what's going on. Hands, by the way, are the skills. Do people have the skills needed to do something? Because sometimes it's just a simple matter of that. And don't ignore the heart piece. So help people when it's time to step back or step away from the work and let it go. Bring on new members is needed. And this is where in this transition, you really are bringing we had regional primary care leads. So there were 2 different positions who oversaw, each oversaw a number of clinics. So we've recruited them onto what had been the project team and what had morphed into like a steering team. And you don't have to rely on normal hierarchy to set your lead. So, sometimes, the person who is sort of the operational leader isn't the best person to lead the effort. It's important to involve them, but they may not be somebody who, for example, understands, the larger picture or whatever. Okay. Leveraging your timing. And, I think the takeaway here is, you do want to be careful about tail wagging dog, right? So there was a grant that was released by the state of Wisconsin, and I won't get into the details of it, but we applied for it, and it meant we would have had to have done some things differently in our implementation. And thankfully, we didn't get it, because I think it would have been a little bit of that situation of the tail wagging the dog, where it's easy to like chase money or chase opportunity, like it comes up. And so you go for it, even though it's not the right timing to do it. I mentioned the NIH grant. There certainly were moments where I thought that I had made a misstep by doing that, because it was really tough to implement. But I think overall, it was tough to implement, but I think that there was enough rationale for doing it at that time beyond just, oh, gee, it's so great to, be a part of these studies and, to do the research. We started with adults and then added pediatrics in, and similarly to the adding, the substance use disorder population and, pediatrics, there are different, measures you might be using. You might be looking at different diagnoses, there are differences. Certainly our pediatric clinics had different workflows than the other clinics. So I think there was a need to really do a design that was more specific to that population. I already mentioned we did sort of a diagnostic ramp in one by one. You can always set up some sub teams who can work at the same time. So that's exactly what I was just saying. So as we were implementing in family medicine and internal medicine, we had our pediatrics subgroup who was in the design phase. So I think it's just a matter of clearly delineating, where people are, and that you can be in different phases for different aspects of the work. I think it's important to both frame those kinds of incremental additions for yourself and for everybody who's working, in it. So I really made a lot of effort to help people frame, like for the substance use ad, for example, not like, okay, now we're going to do this whole other thing and put this on you as well, but rather to say, now we're just integrating another part of the population. These are still your patients. They're still going to, be treated within this model of care. It's just that there are some sort of specific differences, but it's the same as when we did depression and then added anxiety. Is this group all starting with pediatrics? Was that my understanding from last year, or no?
No,
Are you?
it's from different range, not necessarily just pediatrics.
Okay. So flexibility is a huge piece. So I think we've got like perseverance, resilience, sense of humor, and flexibility, right? So now we've got like all the things you want. It's almost like you need a coach who you can meet with weekly, who can say to you, now remember, these are the things. Um, I'll just tell you a story about one of our clinics that was also very good learning for us. And I think highlights the importance of our physician champion, our primary care physician champion. So we had a clinic who, family medicine, of course, is sort of more geared towards, treating the whole patient. And so they had some positions in their clinic preceding when us deciding to go with the collaborative care model, so that they could try to attend to some of the mental health needs, but frankly, a lot of psychosocial, like the social determinants of health. Is a clinic that had a high percentage of patients who had a lot of needs, and there wasn't a lot of resource in that community. Like there wasn't really good access to behavioral health providers outside of the system. So as a result, they had a couple of behavioral health clinicians who worked in the clinic, who really were doing like case management and crisis intervention. So that was very valuable to them, right? It was important and valuable for them. And that's not where collaborative care lives. And so they were pretty worried when we decided to do collaborative care, because they really saw it as a takeaway, from what they already had in place. And then what were they going to do with these patients who were in crisis or who needed case management services? So I think early on, we weren't sort of engaged enough with the clinic leadership there to help them feel comfortable that we weren't just going to rip away the things that they had and supplant it with this other thing. And so there was kind of a lot of pushback and, like a bit of upset and whatever. And our physician champion was important because I think that, I'll just sort of be upfront about it. I think that, the PCPs really felt like she had credibility that I didn't have, because I didn't walk in their shoes, I didn't work in the clinic, I didn't see their patients. And so having her and being able to really talk about what their concerns and fears were was hugely helpful. And what we ended up doing in terms of being flexible is, we still implemented collaborative care in their clinic, but I went to our patient, what was that called? There was a department basically that we had sort of centralized, case management and complex care coordination. And so went to that team and asked them, instead of doing that work remotely for that clinic, can you place somebody in the clinic, so that they still had that case management support that was so important, but they weren't using their collaborative care clinicians to do that work. Does that make sense to people? Like, so that's a way that you can have a both and, right? And then you have other kinds of specifics, like I mentioned the clinic where we had, an addictionologist. And so that changed the complexion of that clinic. A more rural setting, has specific challenges. And I think just to be sort of humbly curious, like you not come in and sort of say, okay, this is what we're doing and we're going to foist this on you. But like, we really want to understand, what your challenges are day to day. And I don't know about you all, but I would guess that you may have had similar experience, that especially during the pandemic, I think it was very tough. I think there's so much about providers and burnout, and, to say something like, oh, it's just one more, it's just a little thing that we're adding to your load. The saying one more click or death by 1,000 clicks, became a very real thing. So to really be sensitive about that. And so that kind of gets us into how to increase engagement. So sometimes you have to build in incentives. Are you able to negotiate workload when adding new tasks? So if you're now asking the MA to, like, let's say you can't automate your PHQ-9 or your GAD-7, or you can't automate it right off the bat. And does that put an extra load on your MA who has to, get something to the PCP? Well, is there something you can offload, to help balance things out? Definitely work with providers and clinic managers when you're identifying roles for tasks, because, from a distance, you might think that, the MA or the RN is the perfect person to do something, but that might not fit with the real world workflows at all. Appeal to what's compelling to people, make connections. We had done a pre-implementation survey of all of the providers in terms of measuring their satisfaction with behavioral health services. So at that point, of course, it was the ability to refer to specialty care. And it was pretty bad. They were pretty discouraged about the whole idea that they were ever going to get their patient in, to be seen. And so then we did post-implementation surveys and, sort of asked the same questions about their satisfaction with behavioral health support for their patients. And it was just night and day. And so, that's one of going to be a really compelling platform. That's a burning platform for most providers. I want my patients to be able to get the care that they need. I'm frustrated that they can't. So, the fact that it's a very patient-centered model, I feel like it was the least hard change to sell ever. I think, we had one physician leader who said to me, can I slip you $10 so we can go next, so my clinic can go next? And he was joking, but not really. It's like, and like, when are you ever implementing a change and people are like, yes, bring it on? So really, if you appeal to the right things for people and help them connect the dots about how much it's going to benefit them and their patients, it's hard to go wrong. Let's see, I'm just going to do a quick time check here. Well, we pay attention to, so measurement, I'll just say quickly, I already talked a little bit about our dashboards. I'm not going to necessarily talk about what metrics we looked at, because I think you want to match your metrics to your organizational priorities. So I'm just making this up, but let's say your organization doesn't have anything in their priorities about improving, I can't even say this with a straight face, improving, patient outcomes, like decreasing depression for patients, then, that metric might not make much sense, right? But you want to be sort of matching it to what the organization's trying to achieve. Obviously, collaborative care also, like, does more than suggest. It really tells you a lot of, like, the clinical metrics that you would be looking at. It's important, of course, to, like, really get to the root cause of things. Like, it can be easy to just say, oh, I know why this is going wrong, but it may not be the real issue. So I think you want to develop a process for doing a root cause analysis that really helps you get to the bottom of things. And then, don't let perfect become the enemy of good. So back to the idea of being a learning organization, you can sort of get paralyzed, right? By, we're not ready, it's not perfect, like we implemented, and the vice chair in psychiatry, who I mentioned, I was my dyad partner, like asked me for a year, is this program cost effective? Is it cost effective? And I couldn't tell him because we didn't have the data yet to be able to say that. And we decided to implement before we had all the billing issues worked out. So that's a good example of how, perfect wasn't the enemy of good. It's like, let's launch, let's go. We know we're going to be implementing the billing model, which is work with payers, with our billing system, with, who's going to do what and how we're going to make it all happen. And eventually we did implement it. And I could tell them, okay, here's what it looks like in terms of cost effectiveness. But, that takes buy-in and from the organization and sort of a commitment to the model, because it might, you might be losing money on it. Initially, it might be an investment without as much of the ROI. And then I don't have to tell you guys that often behavioral health is about cost avoidance. It's not necessarily that we're not orthopedists, right? We're not billing, getting all of this huge billing, but really you do want to look at how are we able to avoid costs of hospitalization, of ED visits, even reduce visits to the PCP because the patient's able to work with within the model. Any questions about metrics or all of that? Anything you wanted to talk about there?
Thank you for joining, Stacy.
Yeah, thanks, Stacy.
Thank you so much. I appreciate it.
Okay. Let's see here. And that's what I have for you today. So again, open it up for comments or questions, discussion. What are you struggling with at this point, no matter what phase you're at? And I won't believe you if nobody says that they're struggling with something. Sure, my contact information. I am going to type back to everybody here in the chat.
In the meantime, if you have any questions, please feel free to unmute yourself. And it's an open discussion. It's a safe space. So please don't hesitate to ask any questions you may have.
I've shown you all our dirty laundry, right? Again, big believer in we'll practice being a learning organization within the context of our meeting today.
And we'll definitely share the slides with you all after this meeting. We're gonna send out a follow-up email with survey link, and through that you'll also be able to access the slides.
Anything that I didn't touch on that you are, finding more relevant or that you were hoping to talk about. Okay, how did you navigate the earliest stages pre-decision to implement? David, say more about that. You want to unmute and you can just ask me. Oh no, wait,
I
sorry.
don't think he's able.
Sorry. Yeah, we can't make your sound work. Do you mean the design phase or like
Design, I think he said design.
design? Yeah. So I you know, the way what that looked like was to have some key stakeholders come together and so what had happened is there had been sort of a mini organizational study. I think two things came from that study. One was that they needed my position, which was the Senior Director of Behavioral Health. And the other thing was that they were going to implement integrated care. And so then what they did was stand up that design group that was made up of, a pretty varied group of people. So it had some executive leadership. It certainly had clinical leadership. It had, people from quality assurance, from finance, to talk about which model, because I think that, David, that is a really key question. Like, it's one thing to say we're going to do integrated care. We think that's the right strategy, but then what is the right approach for the organization? And so, frankly, I think that decision was largely probably guided by the fact that it was an academic medical system. So there, I think, is a leaning towards or a tendency to feel that evidence-based is, the way to go. And so I think collaborative care certainly has a lot of evidence behind it. Primary care behavioral health model, less so, although I think they just came on the scene differently, right? Collaborative care was, something that was created and studied, huge numbers, right? And then I think that primary care behavioral health was something that grew up more organically, more roots. And then you had to kind of go back and say, what is this achieving? What kind of outcomes are we getting? And so you clarified getting people on board to make the change. I mean, I think again, it was the easiest sell ever. It kind of sells itself. Now, it doesn't mean that, people don't bump up against the reality when you get into it of is doing things differently, and that's challenging. It might mean more work for me, and that's challenging. And so you have some of the same challenges once you get into implementation. But I think at the front end, I'm not sure I have like huge insights to share with you, because I do think that it was such a compelling case on the face of it. I guess the one thing I would say is making sure that you're really emphasizing and highlighting, again, back to that idea of what's the burning platform, what's compelling to the people that you do need to get on board, what's in it for them. And it's not hard to connect those dots at all, but so help them understand what the model is and what it can achieve for them. That's what I would say.
There's a follow-up question from David. He's asking, did they understand that integrated care meant keeping more people in primary care rather than carving them out to specialty care?
Yeah, great question. I think, and this is going to depend on your systems and where you're at, I think. People did understand that, and I'm so glad you asked that question. And they already felt like they were holding the bag, but they were doing it without help, right? So it was very value add that all of a sudden then they had, more support in doing that work. But the other absolutely key thing that we did, and this isn't like a set part of collaborative care, but we created a pipeline that went in both directions. So we had collaborative care, we had the consulting psychiatrist, but I assigned a role in specialty care, so in our psychiatry side, to facilitate the referrals from primary care, the primary care clinics that had collaborative care to specialty care. So in other words, because we had much more clarity about who can stay in primary care and be treated successfully, then there was a higher comfort level in specialty care that they were getting the appropriate patients rather than primary care going, oh, just take all these people and, you know, solve their problem. So that was potentially one of the most valuable components that we implemented, I think.
Angie, did you have a question?
Well, yeah, I just wanted to kind of inquire a little bit about, so I do a lot of work with rural primary care practices.
Yeah.
And, clinicians are very far and few, but I was curious to know, like, when looking at collaborative care, preparing the team for understanding kind of their role, and some of the practices that and having champions was absolutely, crucial, because it was kind of like there were some that are just really hesitant to bring this on. But, when there's a champion that can kind of, I think peer pressure is the best pressure when, coming to providers and being able to look at outcomes and decrease in utilization and things like that. But I found that, practices that kind of had an identified nurse RN or kind of a care manager lead that, worked, kind of took the role, the kind of lead in that, was was more comfortable in talking to, like, next steps. Because I think so often it was, well, here's a list of therapists, here's a list of psychiatrists, and there you go, and it doesn't happen. Once patients leave the clinic, it's like, it's overwhelming.
I think they say something like only 30%, less than 30% of patients make it.
I think it might even be more than that. But, you talked about workflows, but, have you found like practices that can identify a key person on the clinical team to kind of be that in-between person when, they're not co-located? An example is there was a practice that, kind of searched around and talked to even private practice therapists, and, kind of talked about what their hope was. And they found a practice, and they were amazing in that, kind of helping the team understand, what do we need to make this referral kind of seamless? What sorts of information can we get up? And then it was that one person that just did all the follow-up. And, it took a little while, but then, like you said, the communication lines kind of go back and forth, which is, really important, because I think in primary care, everybody's busy, but it's closing that loop.
Yes.
Did they show up? And, so I don't know. I guess in all of the work, some of the frustration, and it's hard to help primary care clinics see the investment on the front end, whether that's, hiring additional staff to be that key person to, follow the referrals and, advocate and support and kind of give patients the confidence that this is, a good thing. Again, I think that goes to the stigma piece that is difficult. But again, just curious, like, how do you bring it to the team and understand that they all have a vital role in being the success? And what successes have you seen in that?
It's a great question. I mean, I think that a piece of that was establishing that role, and it was like a patient resources role it was on specialty care side, but then that person was also responsible for they would go, and it was all in one system. So this is the way they could do it. But there's other ways you could make it happen, right? If you're working outside of the system, that person was responsible for sending the message back to primary care saying your patient made it. They came in, they had their appointment. And then everybody's accessing, the reporting workbench. So everything about they're truly working as a team. So that concept of team, and I mean, I think that's probably the key thing. It's like primary care, you're no longer over here holding the bag by yourself. All of a sudden now you're team. And it was so contrary to the experience that they had before we implemented collaborative care, where psychiatry was over here and it was like a black box to them.
Yeah.
And so creating that, and we created some workflows, like our psychiatry head, person and our primary care leader got together and said, here's where we agreed, like, here are the patients we could see over here. Here's who we want to get over there. And here's what the workflow would look like. And here's how the communication works. I mean, the relationships were transformed.
Yeah.
And I think that whole package was at the core of it. Now, we did have our behavioral health specialists also like holding a piece of the coordination, right? Like not, hopefully avoiding like the rabbit hole of like, oh, now they're a case manager. But,
right.
It's important for that person. Yes, your role is doing behavioral activation, motivational interviewing, short-term therapy, blah, blah, blah. But be careful not to be too rigid. Like you don't want to be co-opted into now you're the crisis support for the clinic, but you are part of that primary care team now. And I think that was huge. And so you need to be flexible enough that if that patient comes in, they're in crisis, their NP is in with patients and can't free up, you can step into that space and help. But and the rural clinic thing is like, that is another layer of challenge.
It is.
Like we had 2 clinics where we split a behavioral health clinician. So she covered 2 clinics because they didn't have enough volume in either place. And then the pandemic, one of the silver linings was like us learning that telehealth really works. And so utilizing telehealth to like extend reach. And like sometimes, those patients don't have broadband too. So they don't have the same resources. So we set up like a kiosk in the primary care clinic. So the patient could come into primary care, which they could get to, but then have like their session with the clinician who's 2 hours away.
Nice.
Things like that.
Yeah. I hope that all the forward movement we got with telehealth does not go backwards at all.
No.
It was
I
hard
don't think
for
it
some.
will. Yeah. But we were so wrong in our predictions, right? Like people hate it, patients, they can't wait to go back. It's like, oh, actually, most people loved it.
Getting them in the office to physically see them to do, it was just like, do I really have to? So I mean, but that's a good thing. It was a good experience, I think. And I think, again, for providers that were a little resistant and worrisome, they kind of was like, whoa. So again, I just hope we can keep forward thinking with that.
Yeah, that's right. I mean, God, we tried for years. I kept saying, we need to be doing some telehealth. And it just was never a big priority area. And then Friday, the end of day, then Monday we opened the clinic and we're doing 100% telehealth. It was like, that was a good silver lining of a terrible situation.
Agree. Yeah.
I see we have 1 minute left.
I was just gonna say, I want to be mindful of the time here.
Yeah,
If
and I want to
anyone,
be respectful of people's busy days, and so I put my contact information in the chat, so you have that. If there's something follow-up you'd like to ask, or you didn't want to bring it up in the whole meeting, I'm happy to share you know, what any learnings that we had that might be a benefit to you. You can do it. And then I did have one last slide, just so if there's a link in it. If you get a chance when you get the slides, just plug that link in. It's just a very, very short video. And I don't know if you've seen the movie Galaxy Quest. One of the best movies ever. I suggest you see it, but this is just a little clip from it that is very germane to our discussion today. So if you'd like a little chuckle, you can take a look at it.
Definitely. Well, thank you so much, Beth, for your time today. And
Okay.
thank you all, everybody else who joined. It was a pleasure having you. And we're almost to the end of our Echo series for CoCM. We have our last session next month in December, and that's going to be hosted by Verna Little. We're also going to send more information about that in upcoming weeks. But please be on the lookout for our follow-up email. And CEU we will be providing CEU that you can use as a certificate of attendance that you can use as a CEU for this session today. If you have any other questions, please feel free to reach out to me. But if not, thank you all so much for joining again, and have a great day. Bye, everyone.
Good luck, everyone.
Bye, Beth. Thank you.
Bye-bye.